My name is Chantel, and my group members consist of Kaylin, Kazar, Anna, Marina, and Mackenzie. Our topic choice today is amyotrophic lateral scoliosis, also known as ALS. Here's a presentation overview of the points we'll be going through today. First, we'll be focusing on ALS's consistency with the definition of chronic disease. Then we will move along to the descriptive epidemiology of the disease, then the main characteristics, the signs and symptoms, how ALS is a complex disease, a rehabilitation strategy, and a relevant research publication. Consistency with definition of chronic disease. ALS is a disease that persists for a long period of time. It advances slowly, causing symptoms to worsen over time due to a loss of motor neurons. What are motor neurons? Motor neurons are nerve cells responsible for transmitting signals from the brain and spinal cord to the muscles. This enables voluntary movement. They have long axons that connect the muscles throughout the body, making it challenging to establish new connections and restore function once lost. This causes the disease to be incurable. The nature of the disease means that individuals require ongoing medical treatment and support to manage their symptoms and maintain quality of life.
So now we'll be talking about the descriptive epidemiology of the disease. ALS is actually considered a rare disease in Europe and North America. It has an estimated prevalence rate of around 10 to 15 people per 100,000 people, and although the disease can strike at any age, symptoms most commonly develop between the ages of 55 and 75. The average survival time after onset is between 2 to 5 years. However, how long a person lives with ALS seems to be related to age as well. So people who are younger when the ALS starts tends to live slightly longer. And ALS is 20% more common in men than women. However, as the age increases, the incidence rates become more and more equal between men and women. White non-Hispanic individuals are at an increased risk of developing the disease compared to Black and Asian people. If we look at this figure, we can see an increase in cases of ALS around the world, which is predominantly due to the aging population, especially among developing countries. According to research, the cases will increase from 222,801 in 2015 to 376,674 in 2040, representing an overall increase of 69%. And if we take a look at the picture, the majority of the changes will be seen in Iran following Libya, with an increase of 112% and 117%.
Main characteristics of ALS. ALS is characterized by the progressive degeneration of motor neurons in the spinal cord and the brain. This means that motor neurons, which transmit signals from the brain to the muscles for movement, slowly deteriorate over time and eventually die. ALS is also known as Lou Gehrig's disease. Lou Gehrig was a famous baseball player who passed away from ALS. It is important to know that ALS does not impact a person's mental function, their senses such as their hearing, nor it is an infectious disease, so it cannot be spread from person to person through contact. And as ALS progresses, patients report an increase in the number and the severity of their symptoms, which will be discussed in the next slide. The signs and symptoms of ALS include muscle twitching, especially in the arms, legs, shoulders, or tongue, muscle cramping, muscle atrophy, which means that muscles decrease in size, and what comes with muscle atrophy is plasticity, and this is the stiffening of muscles. The next symptom is fatigue, which is usually persistent in patients with ALS. Also, speech impairment. And later, as ALS progresses towards the later stages, patients report to have breathing difficulties known as dyspnea and also paralysis.
So, one of the reasons as to why ALS can be considered such a complex disease is because it is so multifactorial in nature and its etiology is rather unclear. So, it's believed to be triggered uh, by a combination of both genetic and environmental factors, which are, of course, going to interact with each other uniquely in each case of ALS. So, although there are dozens of genes that are actually associated with the development of the disease, variation in 4 specific genes are present in up to 70% of individuals with familial ALS. However, these familial cases actually only account for about 5 to 10% of all cases. The other 90 to 95% of cases are sporadic, and in sporadic cases, there is a significantly larger number of gene variants associated with the disease. So they're estimated to be roughly 23 genes directly associated with the development of ALS in sporadic cases, and the probability for each gene ranges from 25 to 99% depending on how many gene variants are present in the identified genes. So while there are dozens of genes associated with the disease's development, the relationship between gene variants and disease mechanisms is actually largely unclear, especially in sporadic cases, meaning that while we can identify specific genes associated with ALS, that doesn't necessarily mean that we can identify the root cause of the disease. So along with differences in gene variants, variation in gene expression further complicates the disease as it alters phenotypic expression and susceptibility to developing ALS. So on the other hand, environmental factors also play a significant role, and they are estimated to account for some susceptibility and variability in ALS development. However, there is only one environmental risk factor that has significant statistical relevance in ALS development, and that is, of course, smoking. So along with smoking, oxidative stress, or any factor that contributes to a pro-oxidative state in the body can be considered an environmental risk factor for the development of ALS, as oxidative stress is believed to be a primary mechanism in ALS pathogenesis. So some other environmental risk factors that are estimated to pose a very probable risk to ALS development include exposure to lead, pesticides, and service in the U.S. military. However, more evidence is required before any conclusions can be made regarding the association between these factors and the onset of ALS.
The rehabilitation strategy for ALS is multidisciplinary care that is provided by treatment centers or ALS clinics. So multidisciplinary care is care that is provided by a range of specialized healthcare professionals, and these healthcare professionals must provide coordinated care and have clear communication because ALS patients have complex needs. So in the US, this multidisciplinary care is provided by ALS Association, treatment centers of excellence, or recognized treatment centers. And as well, there are ALS clinics. However, these clinics are separate from the ALS Association entities. So the difference between the two ALS Association treatment centers are that the one of excellence also takes part in ALS research while providing that multidisciplinary care, and the recognized treatment centers do not take part in research. However, in the ALS Association, the care is focused on quality of life, hope, and being provided in a supportive environment. And in the ALS clinic, even though the care is still multidisciplinary, it's a separate model from the ALS Association. So who is part of the multidisciplinary healthcare team at the ALS Association? It is a wide range of professionals, including the neurologist, who looks at neurological function, the clinical coordinator, who pays attention to the organization's flow, the mental health professional, who looks for changes in thinking and behavior, the pulmonologist, who looks at breathing issues and pulmonary infections, the respiratory therapist, who looks at breathing and educates the family and their patient on how ALS affects the lungs, the occupational therapist, who looks at ADLs and helps the patient cope with the muscle weakness that comes with ALS. There's a physical therapist who recommends exercises, looks at muscle strength and balance, and who can also provide mobility aids. There's the registered dietitian who looks at eating and swallowing, looks at calorie and fluid intake and provides recommendations, and who also can provide nutritional supplements. Then there's the social worker who can provide information about health benefits and who also can discuss financial or work concerns and even be in a psychosocial support role. There is the speech-language pathologist who looks at speech and swallowing and may also provide supplemental or alternative communication methods. And then there is the nurse who provides information about the disease itself and information about the care plan, and who can set up meetings with the specialists. And there is also the ALS Center Care Liaison, who provides referrals to community and specialty supports, and they might also provide resources to help the patient deal with the daily struggles that they face when it comes to having ALS. So as you can see, the multidisciplinary care team has a lot of professionals, and this is because ALS patients have many areas that are impacted when they have the disease. So they need help in many different areas of health. Now moving on from the multidisciplinary healthcare team to look at ALS care in Canada compared to the US. And this is done in ALS clinics in Canada. And this is different from the ALS clinics in the US because Canadian ALS clinics are more of a match to the treatment centers of excellence provided by the ALS Association. And that is because they take part in ALS research and have the multidisciplinary healthcare team that is a match to the treatment centers with the neurologist, the speech-language pathologist, the OT, the PT, the respiratory therapist, and all those other types of healthcare professionals. And one example is the ALS clinic at the Sunnybrook Hospital in Toronto. One thing I want to add on that I did not mention earlier, but that is important to mention, is that the occupational therapists and physical therapists that are part of the multidisciplinary healthcare team try to ensure that the patient who has ALS is able to maintain as much of their functional independence as possible.
In the relevant research publication, researchers evaluated the effect of an ALS multidisciplinary care clinic in Spain. This clinic was established in 2001 with the aim of delivering continuous care for ALS patients by a team of specialists. These include a neurologist, pulmonologist, nutritionist, endocrinologist, rehabilitation specialist, physical therapist, psychologist, social worker, nurse manager, speech therapist, and administrative worker. Patients visited the multidisciplinary care clinic every 3 months, whereby their pulmonary function and nutritional status were assessed. To examine the effectiveness of the multidisciplinary care program, researchers compared demographic and survival data of patients who attended the multidisciplinary care clinic with those who attended a neurology clinic. The researchers prospectively followed 334 patients with probable or definite ALS who were treated in the multidisciplinary care clinic from 2001 to 2012. In contrast, 54 patients with probable or definite ALS were observed retrospectively from 1991 to 2000. These patients did not receive multidisciplinary care and were treated by a general neurologist at a neurology clinic. Patients treated in the multidisciplinary care clinic were more likely to receive certain interventions, such as riluzole, non-invasive mechanical ventilation, and gastrostomy. In patients receiving non-invasive mechanical ventilation, multidisciplinary care was associated with quicker access to this treatment. Patients treated in the multidisciplinary care clinic also exhibited a higher median survival time following symptom onset. Due to the fact that a comparison group was included, so those who received treatment at a neurology clinic, this research effectively demonstrated the positive impact of multidisciplinary care on ALS survival. However, a major limitation of the research is that the two patient groups were from different time periods, which could have biased results, because treatment at neurology clinics in 2001 to 2012 might have actually produced better outcomes. Another limitation is that information pertaining to quality of life was not collected. Here are our references for the information that we used, and here are our references for the images that we used. Thank you for listening.